So thank you, it's really interesting to follow this really great presentation. You'll see that now we're switched focus, and one of the things that we've been doing in the HCV prevention is to try to stay in the prevention, because when you're talking about HCV, obviously talking about prevention, you're talking about treatment, you're thinking about access, awareness, etc. So it's been a little bit of a challenge to make sure that we stay there. The other thing I would like to say is, and it will come back. I'll say it after. So the working group that we had a tremendous working group. Navid and myself were the co-lead, but Adelina here, who is a PhD student in my group, but also a trainee in CanEPC, really did the draft, developed, and it did the whole thing. And she's been doing a lot of research. What we've been doing is looking into, obviously, trying to focus on the WHO, how the PHAC structure the strategy, but also looking at other plans in other countries to try to see what are the variation versus the common ground, and try to come with something that is really adapted to Canada. And the members of the group you see here, so we function a lot by consultations, emails, and we thank obviously everybody. So what I was going to say is, when we're talking about prevention, and we're talking about key populations, obviously the majority of 70 to 80% of HCV transmission in Canada is attributed to injection drug use through sharing of contaminated needle, syringe, and other equipment. And although the national estimates are lacking, this is a very this is an ongoing epidemics with high level of transmission still. Obviously, the highest rate of infection are also documented in subpopulations who bear a disproportionate burden of injection and related harms, and we've been talking about this. So when we were looking at prevention, obviously you'll see a lot of things that are related to injection drug use, but we'll also address the other key populations at the end of the presentation. So we kept 6 key objectives for our group, which is increase surveillance of HCV to orient and evaluate prevention and care activities, decrease new infection, decrease reinfection, support development of an HCV vaccine, support the research to address knowledge gap in HCV prevention, and also decrease stigma associated with HCV. Obviously, some of them, the indicators and targets are easier to get than the others, and that will be something that I will certainly be happy to have your feedback on. We also try, because the PHAC document is so large in the syndemic, to really focus on the things that are mostly important and specific to HCV. So the first target, and we've decided to, the targets, we kept the targets at the new infection and reinfection with the 2030 milestones, just because 2020 is just down the road and it doesn't matter anyone, I guess. But for the surveillance, we kept the targets at 2020 because we obviously think that we have to move very quickly to have some baseline data and be able to follow the impact of what we're going to suggest. So the first objective, so I'll go back to the 6 objectives now. The first objective is to increase surveillance of HCV to orient and evaluate prevention and care activities. And I guess, and most of you in the room are struggling with this thing, we don't have good numbers. We don't have good estimates. And we need provincial and territorial level data platforms to measure incidence of HCV through the integration of laboratory administrative databases. And this is something that has to be addressed. Now it's province by province, place by place, but it has probably to be addressed somehow, somewhere else at a higher level. The second is to support the established cohort to monitor incidence of new infection and reinfection, injection practices and risk activities, and the trends. It's that administrative database has their limitations, modeling has their limitations, and if we combine this with observational data, we have much better estimates. The third one, 111, okay, it's all the same. But the third one, I think they're all important, is to support the implementation of a pan-Canadian annual survey of people who are injecting drugs and other key populations by securing a federal recurrent financial support to iTrack. We wanted to be very specific here, A-Track as well and Amtrak as well, because this is something that is so useful, so important. We use the one that is 2010-12 right now, and every single time it takes, I don't know how many years to secure another one, and you don't even know if it's going to happen again. So this is something that I think we strongly, we were very specific. The second objective is decrease the new infections. So obviously, the two main cornerstone of harm reduction strategies is needle syringe exchange programs and also opioid agonist therapy. So expand needle syringe programs. We estimate the need to, WHO is 300. We're already there in Canada, average. Because when you're looking at places, that's another story. So we estimate through the iTrack data, and we did some extrapolation with the frequency of injecting in the survey and also the number of days they were injecting. And we estimate to at least 1,000 syringe per people who are injecting drug per year to cover the needs that seems to be there by the survey. I think it's a very good example of how we can use those type of data. Targets should be also monitored and take into consideration the variation in drug use patterns across provinces and territories. Obviously, some places with very high burden of injection and overdoses, as you said, they might need something like a flood of syringes, access in sufficient amount, but we shouldn't forget the places that are hard to access as well. Opening hours, access points, etc. So the second one is opioid agonist therapy. There we don't have good estimate to the real need of OAT, obviously, because there's a lot of problems with access, and there is a lot of problems as well to estimate what is the size of the population that would need them. Vancouver is Vancouver, but outside of Vancouver, there is the rest of Canada, and there is a lot of blind spots over there. So offer access to various forms of OAT, including methadone, buprenorphine, naloxone, and other opioid agents. Offer access to OAT through different healthcare professionals, including pharmacists, nurse practitioners, in various settings. So now we're also having in mind the syndemic with the opioid crisis, and this is all going together. And also in this particular objective, we support the modeling study. We would like support for modeling studies to evaluate the optimal coverage of harm reduction services in Canada, because this is something we'll come back to some other ideas for evaluation and research, but this one is specific to this particular instance. So decrease new infection. There is obviously all of a set of other things that have been evaluated and estimated to be useful. So I just won't go through all of this, but this should be there. We try to really focus on the ones that we want people to pick up, and the wish list, as Jordan said. So this is obviously important. I just want to point out, and I'll come back to this, that we offer access to and encourage use of condoms among MSM. And then we would like the feedback, because this is something that we were struggling with, saying, well, a little bit like we should focus on everybody. Well, the MSM population, that should be specifically a key population for the prevention of HCV. Maybe it has to be a little bit better defined or specified so that you have targets to measure that won't cost, monitoring MSM behaviors in Canada, for instance. So this is something that we would like to discuss with you because there was a lot of discussion. Monitor the potential effect of HIV PrEP on HCV transmission. I think it's one that should be flagged. Implement a substance use curriculum. This looks remote, but this is something that we've just discussed before, and this probably should be flagged because it goes with being able also to deliver treatment as prevention. So that's why I'm saying keeping in prevention, but still I think it has to be there. Objective 3, decrease HCV reinfection. Obviously, the activities for prevention of primary infection is also relevant to reinfection, but we also flag some of the other tools and activities that could be useful for that. Integrate HCV treatment and care in OAT and other harm reduction and social support systems to prevent reinfection. Provide HCV RNA testing on a regular basis after treatment. Research and support the implementation of treatment as prevention strategy. Retreat HCV reinfection. Obviously, this is something that has been shown to be effective to reduce HCV in this population, and also research and provide access to services and harm reduction programs specific to HCV reinfection. We're not quite sure that the factors that will drive the reinfection among high-risk population that have been treated will be the same as the other ones. Support vaccine development. Vaccine, if a vaccine was available, vaccine is the key for elimination of viruses in the world in general. And I think in Canada we have a leadership in vaccine development, and this is something that we should push forward, including measure acceptability and feasibility of vaccine program. And I think there it's including everything that I've been saying, obviously is with the help and communities, but this is particularly important as well because you can develop whatever vaccine and chances are the vaccine won't be 100% efficient, but if nobody wants the vaccine and there is no acceptation and interest in the vaccine in the key populations, it won't be very useful. So there is a list of support research activities to address knowledge gap in HCV prevention. And I used to say that, we're all focused on needle exchange and opioid agonist therapy, but there's so much more you can do. And in Canada in particular, needle and syringe programs are difficult to prove to be so efficient because of the stimulant, because of the whole other type of issues and barriers. Doesn't mean that it's not important. It means that we need more than that and we need to understand better. So these are the list of the activities that we flagged. Maybe just look at the sixth one, which is development and evaluation of prevention intervention targeting HCV risk associated with chemsex, mostly slamming among men with sex with men. And these are the things that we were discussing before. It's saying, okay, where do we put our focus and interest and really look into what would be the priorities for HCV prevention? Not HIV, not TB, but HCV. Oh, so and I'll shoot it here because we can maybe in the discussion look into this, but then with the epidemiologic hat, we're looking at, okay, everything's nice, it makes a lot of sense. How do we measure how do we find the data to do a pre-post? How do we monitor and how do we convince policymakers, because they like numbers, they like modeling, but they like numbers. So we've looked, and this is actually why we ended up putting our first priority as the surveillance, etc. Because without all these numbers, probably all the rest of the morning will be very hard to operationalize. So that's the key. The second thing that I want to mention on these two big tables with a lot of numbers, but you see that I think I want you to see the exercise. We could go line by line when we discuss. One of the very hard thing to measure and to monitor is how we target and influence the discrimination and stigma. And this is something that is ongoing with many other diseases and conditions. And this is why we don't have a slide on stigma discrimination, because it's, I think the key population has addressed this. And for us, it's something where we want it as an objective. We didn't put a lot of flesh on it for, I think, all the same reasons that everybody has been seeing before. And then, this is my last slide, consideration relevant to the key population. So we use the key population without thinking of it. With men who have sex with men and gay, lesbian, etc., all the other letters, testing and prevention activities in sexual health clinics, awareness obviously, and also HCV testing in PrEP, and all the probably the counseling that has to be developed around the PrEP and the HCV. We certainly have to measure also how sex versus drug, what is the relative contribution of those two, and not only among co-infected men, but also among men who are not infected with HIV. Newcomers, education about transmission, incarcerated individual, needle syringe exchange, opioid agonists in prison, linkage to harm reduction, social and HCV care services upon release. Obviously, we didn't touch the treatment in prison because it's not in our turf. Indigenous individuals, culturally appropriate approaches, and this is true for people who are using drugs as well and other populations. Community readiness and awareness, harm reduction with Indigenous leadership in communities, Indigenous wellness approaches, and access to holistic Indigenous healthcare services. And I think when we're looking at those things that make so much sense, we should take this language and put it in there, and thanks for people in the Indigenous communities who bring this language to the table. Pediatric adolescent education in schools, to be discussed. I mean, this is something we've struggled again when we're looking at prevention and HCV. Probably the prevention with a good vaccine would be to push for having everybody vaccinated. That would be the best prevention, like in HBV. Baby boomer to be discussed with this section on screening and treatment, and people who are injecting and using drugs have been, I think, largely covered before. So that ends that part, and now we're happy to. And now we're three of us.
Lindsay Jennings from PASAN. So I guess I just have a couple questions just around clarification. What does slamming mean?
Slamming is let's say rough sex. Huh? No? Oh no, slamming is injecting while having sex. Yes. Lisa, go ahead and.
I think it was. I'm going to be very honest with you. That was like a rhetorical question for myself because okay. I understood what slamming meant. I just feel that it's really rough and it's really it's a little bit gross. Sorry.
Okay.
I find it pretty offensive using the word slamming.
Well,
I think the reason why I want to clarify some terms is because I think it's important that going through all of these sections, that if we want to make sure around stigma, that let's start with the language and carry that across every single working group and every single platform.
And this is, I think for that was taken from research question that people have, and I totally agree with you.
And I guess so. Another question is, what's substance use curriculum?
Substance use curriculum. This is in my ballpark. So it's really, and it's obviously, this is a slide, so I just cut and paste. But the idea is, when we want to address stigma, discrimination, and also access to barrier, it has to begin early on in healthcare professional curriculum. They have to learn it at school as they learn diabetes, hypertension, etc. Okay. And then that has to be mainstream. And a lot of literature now shows that you're able to populate the cascade of care for HIV, for HCV, but try it for drug use treatment or drug use care for people who are using drugs, and it's impossible. So when you're thinking about prevention of HCV, one of the backbone is having the base population of people ready to do it, and not just the specialists. That's the idea.
Cool. Okay, that's great. Thank you for that. And I guess my last thing around prevention is, part of the prison population that we're talking around treatment, but yet in prevention we're saying linkage to harm reduction services upon release. That's a problem for me, because
but they were in prison as well. Both of them.
No, yeah. So, just on the objectives, you had linkage to harm reduction services upon release, and so yep. No.
And we know, but we have wait.
It was the last slide, I believe.
Yeah, sorry.
No worries.
It was needle syringe program and OAT in prisons.
Right. Yeah. So my point is the linkage to harm reduction and HCV care services upon release. Part of prevention needs to happen inside the jail, because we have an overdose crisis that's actually happening not just in the community but in our jails. We know that people are using drugs inside. We know that people are having either consensual, non-consensual sex inside as well. So I think that some of these considerations, that it can't be just upon release, that we actually have to push. For my job, I have to push against corrections to have harm reduction services within the institution and to support that.
Okay, but aside from needle syringe programs and OAT, you would like us to add and other prevention services?
I would like harm reduction programs, education programs, services inside the institution.
Yeah, but that's exactly this. So, I understand what you're saying. You're saying you would like something to
So
be
NSP
broader.
and OAT is very different than me going in and doing harm reduction workshops inside of an institution, talking about how to safely use drugs inside of a prison setting.
Right. No,
right? How to tattoo safely inside of a provincial setting. So NSP and OAT for my job does not include my role.
Okay. Yes. I guess idea is, if we get NSP and OAT in prison, that's probably a big crunch to get the rest of it, but we'll done. We'll add it.
Still Curtis Cooper. So the issue of education in the schools touches on a bigger issue, and that's the consistency, the continuity of all of these efforts to address hepatitis C as political parties change in provinces and in nations. And we're already seeing that here in Ontario, where the sex ed curriculum will once again be revamped because there's a new party. So I don't know how we do this, but it's somewhere in the document there needs to be a strong statement indicating that these good things in all of these fronts that we're talking about, they need to be maintained indefinitely. Otherwise, we can't be successful if they're being built up and then taken apart every 4 or 5 years.
Yeah.
Still Brian Conway. These documents are really neat if they're visionary and they move forward. I think two things that caught my eye were this idea of a national sort of survey or something of people who inject drugs and get some idea of where we stand in terms of enumerating the population and its characteristics. As you know, that has not necessarily been very well done across the country. And the estimates, the confidence intervals around the estimates are so broad that they're not as useful as they could be. So if that can come out and it relates to hepatitis C, and that's neat. And the second point is you're going beyond the WHO sort of standard for needle and syringe programs, going from 300 to 1,000. And on the face of it, that sounds cool. And it sounds like it's a bit based that we're so close to 300 on average that we want to go beyond that. But what data do we have that going from 300 to 1,000? Like the WHO came to 300 for a specific reason, and there's data behind it. But 300 to 1,000 does what? And if that can come out in the document,
but we actually have a long paragraph showing the PHAC eye-track data. So it's the national survey that was 11-12. That we use the frequency of injection and the number of days injected.
Oh, to my first point. Oh.
Yeah, and that's how we did it. And the second thing, we acknowledge that we don't have a denominator for people who would, on the opioid, would use opioid agonist therapy because we don't have that. We have the number of people on OAT in Canada. We just have estimates of people who would need OAT. So this is something that we decided to put.
Oh, sure. To my first point, counting. But I think that's cool to do, and that's an actionable item. That's kind of where I'm coming from. And then the NSP goal, revamping it from 300 to 1,000, sounds. It's intuitively sounds good, as long as we know that we have some, at least a credible hypothesis or some knowledge that going from 300 to 1,000 will create a benefit, or that there's something that we're going to measure. Because WHO came to the 300 based on.
But it's an international average based on we're at 40, we want to be at 200 and then 300. What we used is really the needs of the people, given that we don't want people to share their syringes and we don't want people to reuse their syringes, which is...
So that'd be the reason to go from 300 to 1,000.
Exactly.
Is at 300 we think there's still significant reuse going on, and at 1,000 there'd be less?
2 out of 3 times you inject, you don't have a clean syringe.
So she's saying they use the eye-track data to estimate the frequency of drug use.
Estimated,
and suggest that 1,000 would get.
Actually, we did something a bit more complicated. Yeah. We estimated the eye-track and we used our cohort, and we got the average of the two numbers.
Perhaps I'm not asking my question clearly, is that if a document such as this, which we're trying to perceive as visionary, were to come out and say that the blueprint that a group of experts in Canada has produced is suggesting that a standard that makes more sense than the 300 for Canada would be 1,000 per user, and this is why.
Yeah.
This is the benefit that we think it will have.
Yeah.
But the benefit that you have is that we think that this will cut down on reuse. Yes. Yeah, I suppose.
Exactly. So a few points. So in WHO document, they do list this target of 300, but they haven't provided a very clear method or the data, like how they came about this 300 level, basically. And that is one of the issues that we had with this 300 number. And when we started looking at the Canadian data in terms of number of needles and syringes used per day, so that number was even larger than 1,000. And so we used eye-track data and the data from Montreal and came up with 1,000. But then we also highlighted and Julie presented that, there needs to be a modeling exercise to model what is the optimal threshold for needles and OAT that is required to reduce the incidence of hepatitis C. Of course, like more needles will reduce reuse, but what is the optimal threshold? Because at the end of the day, when it comes to public health or distribution, you need that optimal threshold. And at this stage, we are starting with 1,000, but this needs to be revised as we go along and have further data available.
Two quick questions. One is so about the curriculum. I think it's an important aspect of what you've put in, and it sounds like you're targeting that curriculum, or at least what you've described, as primarily to healthcare professionals. And I guess the question is, where does it, if and where does it go beyond that? So that's my first question. And then the second question is something which I know you've considered, but I just don't know, and I just wonder whether it should at least be mentioned in this section, is about the treatment as prevention, which obviously overlaps with the treatment and care group, but whether it needs to be stated as one of the objectives here, or targets, that treatment is scaled up, particularly in certain settings where the prevention data are very clear, that, for example, in the prison system and things where it might just be worth having it as to really highlight to people who don't think about this all the time that part of prevention is treatment.
I think we thought that Tracy would solve this.
Okay.
Because it's not in the slide, it's more in the document, but it's obviously something like the training component. Actually, some of these things are related to every single other thing, but I think it has to be integrated at the time. But it's. Yeah.
Okay. One other, actually, just as along with the curriculum, one other thing that might be helpful to consider, there's been some reasonably good pilot data and suggestion about expanding OAT services to Hep C providers. So someone like hepatologists aren't really trained in OAT provision. ID docs maybe a little bit, but to actually put that into their formal specialty training, if they're going to be Hep C providers, whether they're primary care specialists or NPs, whatever, that they actually get some training specifically around drug.
And this is something we thought about, but it's OAT within the treatment aspects of it, HCV. We use, because OAT is obviously, I guess, a generic tool to help people who are using drugs in general, and specifically, obviously, opioid. And whether probably OAT, and this is my guidelines from the CMAG, OAT should be available in all primary care physicians and all physicians that have not necessarily that they have to induce them, etc., but when somebody is on OAT, should be easy to pre-prescribe. But that's I think the questions we'll have to ask in some of the preamble and discussion of the guideline, where we've put this, that we don't distract. And this was one of the issues I think we're all going to have. We do this because we want to be HCV specific and not syndemic. And we have the syndemic and then the HCV specific. So where do you put these syndemic approach that we know we need, because obviously we will have to save lives of people because we won't treat them because they're dead, and all these type of things. But at the same time, how are you enough specific to be able to help policymaker make specific decision of what they're going to do?
I guess the only argument I would make for doing it, at least mentioning it or thinking about mentioning it, is that there are a lot of people that, and we're sort of expanding Hep C care, and we're very focused on teaching people how to use Hep C drugs, but we're not necessarily focused on teaching them how to prevent new Hep C infections. Right. Part of it is by targeting people who are already in that world. But for example, adding this to part of the training of people who treat Hep C, I think would be something to at least consider.
I think it's, Thank you. Yeah, it's reinfection. infection?
I have a few comments. One is that Hep C treatment is becoming more and more readily available in OAT clinics. And I actually think we may actually want to look to the ways in which people are getting care, and if it's good care, it's definitely increased a lot. And are those services good? Like the doctors are regulated, but how about the clinic itself? What else does it offer? Some of them don't offer very much at all. So I think we should start involving those conversations with those providers. I'm not sure if specialists, Hep C specialists, I'd love to see Hep C moved into primary care, and some primary care physicians are actually providers of OAT as well. And so just that strong encouragement. One of the biggest preventions of Hep C reinfection would be decriminalization. And so I would love to see this as part of our considerations, would be to add decriminalization, the criminalizing of people who use drugs is probably one of the biggest risks to people reinfecting. I do like that you're looking at 1,000 because as drug use has changed and people's access to drugs, people are using fentanyl. Fentanyl does not last as long as other opiates. It's shorter. We're seeing an increase in people more binge injecting. The amount of people, when people are using, it's a lot more. I would also just say that I would expand on, when we're talking about needles, that we also expand on all of the items used, because not all needle syringe programs actually still provide the filters, the cooker, the water. And I think we should actually just continuously write that out. And I would also say that they should also offer other other tools used for using drugs. That's including crack pipes, crystal meth pipes, straws, so inhalation. I think we need to identify and say that. I do like the idea of increasing iTrack or supporting iTrack, but I am concerned as we move forward about how we talk about people living with Hep C and what our interventions are. I know there are people in this room who like treatment as prevention in terms of HIV, but if you ask people over the years in HIV who are living with HIV, what they feel about TASP, many people will talk about how they find it very stigmatizing and seeing people as vessels of disease. And so we have an opportunity not to do that and see treatment as treatment. So effectively, if we know from modeling, if we treat people who use drugs in specific cohorts in specific neighborhoods, that we will see a decrease of reinfection. And our priority really should be about treating people, which if you ask people from our program, we've refused to be a part of reinfection studies because people who use drugs just want to be able to access treatment and find it rather stigmatizing. So just to add that, I would also say an objective 5, 6, and 7 is the same. And I would remove us trying to look cool by also saying things like slamming. Not everyone understands these things. And the words and languages and culture of drug use changes amongst everybody. So yeah, that's it. Thanks. And also, when you say 6 months testing, we need to be really careful that we are not increasing surveillance of people and that people still have autonomy and self-determination in their healthcare, which should always be a priority when we're talking about people.
That's for sure. But I would like people as well to give us some suggestions of comments about how to address prevention among men who have sex, men, gay, and lesbian, because what we said before, because this is something, if we have to address, provincial, territorial, federal jurisdiction, and we're coming with a long list, including MSM as a whole group of people in Canada, versus because obviously MSM who are using drugs, I mean, this is clear there. But this is an intersecting and talking about stigmatization. Men who have sex with men don't want to be stigmatized as a key population in itself for every single virus there is. So it's something that we were struggling with.
Laurie Edmiston from Katie. I just want to build on a couple things that Lindsay said, specifically to specifically mention, in addition to harm reduction, to also talk about tattooing programs or availability of safe tattooing services or something in prisons. And I also think that in that section, if we can say something about best practices or to standards that are available in the community, I think that would be really good too, because the Canadian HIV Legal Network, along with CADI and PASAN and CAN, have been engaged in, I think it's been almost 6 years now, suing the government for the lack of harm reduction and specifically needle syringe exchange programs in prisons. And we've been under pressure to drop it because of the pilot programs that are being started. But those pilot programs, we're not going to drop it, and there's lots of reasons why. But part of the pilot programs is 1-for-1. For example. So that's not a best practice. That's not up to community standards. So I just think that language, if Tracy can add that in, it would be...
and we'll make sure that we'll circulate this part to the experts. Thank you. That makes a lot of sense.
So I'm Simon Ling. I'm a pediatric hepatologist at Sick Kids. And I just wanted to have a couple of comments about the children. It's great to be invited to be part of this and for children and youth not to be lost in the mix or forgotten. Just in terms of the education in schools thing, I think it just raises a point that it has kind of been made before, but I wanted to highlight it. I think education in schools is important. It's important for people to be taught about hepatitis C, to understand it. And for sure, we've come across some problems with kids in schools and the way they've been dealt with. I think the key is to remember the relevance to many of those other groups for the children that are involved or caught up with those other groups. I think there's three main populations. One is the children of infected adults. The second is the incomers and either immigrants or international adoptees coming with hepatitis C. And then the third is the often street-involved youth who are injecting drugs or involved in other behaviors that put them at risk. So, when thinking about how to educate and screen and deal with each of these populations, remember the children. So for incarcerated individuals, remember they have children who are at risk of hepatitis C. Indigenous individuals, remember the children. Really, this has to, I think, permeate through all of those groups and through each of the areas that we'll be discussing.
Can I ask you, because obviously we're focused on prevention, so because the other thing, access, awareness, etc., is covered in the testing. So how would you see the focus for pediatric and maybe teen? Obviously, the teens initiation of drug is it's something that, because they get a Hep C the first 3 years, so that's something that is clear. But for prevention purposes, do you see any other specific targets or objective that would be relevant to kids or infants?
Yeah, I think that in terms of the prevention specifically, I think that does focus on the youth who are injecting drugs. We don't know much about that population. I think the ITRAC that was referred to earlier doesn't include younger teens in that study methodology. If a new approach to that is to be proposed, then having some ability to include youth would be important. Education in schools is one thing. A number of the kids who are at risk of this will not be attending the school, may not pick up on those attempts in that environment. There are some street-involved youth outreach programs, shelter accommodation, some healthcare facilities that are reaching out to those communities, and I think embracing their input to this would be another way forward. I think
there may be a suggestion of having a more quote-unquote aggressive prevention interventions in young at-risk teens who are experiencing drugs, because lots of time they get Hep C the first injection they have, so it's something that might makes sense.
I just wanted to pick up on the GBMSM piece and the question marks. So in the priority population group, we did reach out to CBRC based in Vancouver. So they're a new national gay men's health organization funded by the Public Health Agency of Canada. It's a gap in our composition. We recognize it, but we think it's definitely a key area. It's an emerging population, and there are a number of gay men's sexual health strategies that are being developed with sort of PrEP and undetectability without the Hep C lens. So I don't think there's a question mark. I think it's a definite, but we need to engage these groups.
Do we have to, our question I think is, do we have to restrict to, or we just say it's every single MSM? That was more of our question.
I think potentially to
HCV
narrow
prevention.
it, especially with PrEP guidelines, right?
That-
And that sort of
yes.
testing happening among groups that are already identified as being high risk.
Okay. Okay.
I think that there is a narrowing there for sure.
Thank you.
Just it's Lisa from Dalhousie. Just to follow up on that a little bit, I wonder, and I was thinking this as I sat here and have been thinking this as we went through all these populations, and earlier Dr. Klein had made the comment, well, you know, everybody's in one of those groups, really from children right through to older age, and then some other populations. And and many people are in many groups, to your point earlier, of the key groups that we've talked about. So I wonder, does it, for example, I see some people who are MSM in my practice, and I think that they are MSM, but they would identify more as an older adult than MSM because they've decided that they're at a point in their life where they're not having as much of a sexual experience, and or they may have at one point been one of these other groups, but they're not now. I wonder if self-ascription or self-identification as to which group you're most in might help us with some of this. Or it's just a thought, because I wonder, some people are in lots of groups and may not think that they are technically in all the groups at the same time, and I think a lot of MSM would consider themselves, even if you gave them a list of things, not to be in some of those
I understand,
groups.
yeah.
So it's a really so it's a dangerous thing for me to say something that's just come to my head, because I'm sure it's never a good thing. But I guess the concept coming back to self-identification and the ability to understand who you are as a person, and someone had mentioned earlier, self-ascription for what when we think about testing, not to exclude people, not to make sure we don't offer, but to let people make some decisions about who they are as people too.
I think when we were thinking from GBMSM point of view, it was based on few considerations. So one is, in Europe you have very high incidence of Hep C, and then also studies showing reinfection among people, among this population. While in Canada, based on the studies that have been done in BC, incidence and the prevalence of Hep C infection is not as high as in Europe. So the struggle here was how you could identify or identify a group for more targeted intervention. So so definitely testing is one area, but then also other specific intervention. Based on some of my read and work, the interventions that we have for people who inject drugs, they are not applicable to GBMSM population. So their interventions and their mental health context and the drug use context and the sexual context and the chemsex and all of that requires a very different kind of interventions, very tailored behavioral interventions and drug-related interventions, and the type of drugs that they use are very different from other populations. So that's where we were coming from, how to frame this and how to kind of come to the right focus and propose some of the things that are relevant for this particular population. And most probably we need to engage more people who are expert in this particular area to help us through this process.
Thanks, Naveed, for that, because that's sort of the direction I was going to go. So traditionally, actually, the highest risk group among MSM were HIV co-infected, and then until quite recently, there was relatively low rates of hepatitis C identified in MSM who were not actually co-infected. And the reasons for that are probably multiple, one of which is that there's a synergy between the two viruses, but that it also represents a highest risk group. I mean, if you're going to have both infections, then you obviously had higher risk exposures, whether that be exposure to injection drugs or sexual exposures. But there's clearly that and especially with the advent of PrEP that we're seeing in Europe first, and we're seeing this in Canada, though it's hard to measure and not officially been reported, that this is spreading outside the HIV-infected community. So I think and to Naveed's point, the interventions that we are traditionally used to using with respect to drugs and harms of drugs do not apply to the same way in these communities, because either the communities are not seeing the behavior as a drug use behavior. It's very episodic, and it's often someone injecting them and they're not injecting themselves. There's all sorts of things that go around with the chemsex culture that many people have developed expertise in, particularly, for example, in the UK and in New York, which might help us think about how we could frame that. But I think that I like the idea, and we have the same issues in the treatment of how do we pair this with other STI interventions? Because it's a point of contact. Regular STI screening is a sort of fact of life for those communities that are really at risk. Integrating the hepatitis C care, treatment, and prevention in those environments is probably the way to go.
That makes sense, yeah. Very helpful.
One quick other point about the pediatric group about prevention is whether we want to. It sort of crosses over with testing, but testing women in prenatal care and then accessing treatment, even if they can't get treated for that pregnancy, for future pregnancies to prevent transmission, whether that should be put somewhere in this.
Has to be put.
Yeah, again, and I know it crosses over things, but I just wonder if it just should be mentioned in the prevention side on pediatric to prevent perinatal transmission. Are you guys in line? I'm sorry I'm sorry, I jumped the line. I will say, just in the interest of time, maybe we can limit it to 3 more comments. Is that fair? Because we just we do want to get through the other groups all this morning. Thanks.
So I guess maybe it's a question, or maybe I should have asked it like months ago, but would it be useful to actually kind of maybe separate the prison systems from federal to provincial in a framework? Because I mean, the NSP, great in provincial, we're going to see a couple pilot projects happening, right? But the thing in provincial settings where I'm working in is that prevention methods are actually institutional charges. So if I went and asked for condoms, I'm going to be that's a misconduct, because what are you using the condoms for? Are you using it for sex, or are you using it to package drugs, which then could lead you to be dry celled or sent to SAG, right? If I am asking for harm reduction kits, I mean, I don't even see harm reduction kits inside, period. But even naloxone, we can't even get access to naloxone for prisoners inside. We are reliant on officers. We are reliant on the provincial system. So for people inside, so maybe there needs to be alternatives to the NSP and the OAT right now in a provincial setting, right? And not the federal, because it's happening in the federal, which is wonderful. But the provincial setting is still struggling, and we're also in this place that we don't even know if the Ministry of Health is going to be taking over healthcare within corrections. So I think that we need to be aware of that, if that transition is going to happen, and how that's actually going to either support the strategy or the recommendations or not.
I think we have. I think it's a great comment, and when we're looking at treatment in prison, it's exactly the same thing. There are short sentences, long sentences, federal, provincial jurisdiction. There is no one provincial jurisdiction like the other ones. So I think we certainly will flag this and mention this. Then after that, if we're looking at what we're recommending as optimal ways of preventing HCV in prison, it should be the same for penitentiary and prison in a way. But as you said, the goal would be the same. The means to go there probably are not exactly.
I hear you. So I think the federal level, they have funding. So every federal prisoner that's going in is getting treated. So in the provincial setting, treatment is rare. Treatment is not happening as often. So what alternatives are we going to have in this strategy to address the fact around prevention inside of a provincial institution because treatment is not the main option.
Yeah, but I think, honestly, with the opioid crisis and everything, provincial prison should step up more than what they're doing. And I'm not sure we should give them the way out, but that's...
Oh, I'm not giving any way out. I think I'm addressing the fact that we, as provincial systems, obviously they have to step up. But if we don't have any guidelines that actually address the provincial system and how the provincial system runs, then not many people will actually understand the barriers and the obstacles and the things that are lacking in the provincial system.
Thank you.
Hi, Tim Rogers from Katie, and I just want to quickly give a little bit of a context about MSM that I think is important for the issues that we're discussing in Hep C. So over the last 30 years, HIV has been the primary epidemic among MSM, and the messages have been about use condoms and clean needles. But in the mindset, that's all about HIV prevention. And what's happened is we're moving to HIV prevention methods that are not based upon using condoms, and they're not necessarily based on using clean needles anymore. And so now it's a very dangerous situation, because when we had those messages, people were using condoms, clean needles to avoid HIV, but actually that brought down STIs. That had an enormous impact on sexual health generally. This context is changing, and it's changing right now, and it's changing very rapidly. So I think we can't really even trust what we understand out there, because this is a very dynamic environment. So I think it actually is very crucial for the Hep C strategy that we kind of look at this and do some research on it, and to figure out what does HCV prevention mean in this changing context.
Yeah, makes sense. And according to Jordan, I think it's the last comment.
Hi, Denise Thomas with Canadian Association of Hepatology Nurses. It's great to see the curriculum on substance use. Just wanted to see if we were going to add anything for the curriculum for undergraduate nursing students and medical students. There were 2 posters at the Canadian Liver meeting. Both are saying that the basic knowledge of Hep C is very low, particularly around prevention. And I was one of the poster presenters with another colleague from Newfoundland, and we were talking about it could be even lower than the general public. So just looking at if they're entering in, that they're younger coming in, that...
So make it broader than substance use.
Broader than make it Hep C.
Makes a lot of sense.
Because there's been a lot with HIV, but with Hep C, it just hasn't been talked about. And so maybe a curriculum review, just to update it, and possibly an interprofessional course.
Sure.
With a practicum.
So thank you. It's been very, very helpful. Thank you very much.